Hello and welcome to Approaches to Medicine. Today we'll be talking about diabetic emergencies, and we'll be talking about the two different diabetic emergencies, diabetic ketoacidosis and hyperosmolar hyperglycemic state, also previously known as HONK. Now, I don't want you writing down anything, just sit back, listen. It's going to be a quick 10-minute video, and there'll be a PDF file with all this information in it a little later, so you can download that as well. So we'll be starting with just looking at some of the differences and perhaps even a little bit of similarities between DKA and HHS, also known as hyperosmolar hyperglycemic state. Now, DKA is a triad of hyperglycemia, ketosis, and of course acidosis, while HHS only has the hyperglycemia aspect of things. So it doesn't have the ketosis or the acidosis. Now, if you look at the serum measurements, you'll often see that serum glucose is actually increased in both, less so in DKA, 16 millimoles usually, and that's more of a minimum cutoff. You have that bit of acidosis going on. And of course, you have your bicarb going down as well because of the acidosis, and usually an important, significant anion gap. Now, if you look at HHS, the serum glucose, I know I misspelled glucose there a little, is greater than 33.3, so it's usually higher. We'll get to why that is a little later. The pH is usually normal, and the bicarb is usually not all that decreased. So you can see a change in signs. Here it's less than 18, here it's more than 15. And there's not much of an anion gap. So the anion gap is less than the threshold of 12. Here it's usually greater. And of course the serum osmolality is usually significantly higher in HHS. And again, we'll get back to that later as well. Now, even though these disorders are similar, there are some of these key differences, which again, let me just go back to that. There's less ketosis in HHS, and as a result, less acidosis. And the osmolar graph, serum glucose is greater in HHS, and so is the serum osmolality. Now, DKA is usually seen in type 1 and type 2 diabetes, mostly in type 1, but also in type 2, whereas HHS is usually seen in type 2. And while DKA has a rapid course from hours to days, and HHS usually takes much longer time, anyways from days to weeks actually. And DKA affects patients of all ages, whereas HHS is usually in the older individuals. And the mortality rates are significantly different. In DKA, the mortality is usually surprisingly less. It's usually less than 5% or around 5%. While in HHS, the mortality is actually higher. It's around 15%. And again, that's more because HHS is usually caught later, and the people affected are older. So there's less ability of the body to basically adjust to these changes. DKA, you often see GI problems or GI symptoms, whereas in HHS you often see neurological symptoms, and that goes back to the increased osmolality. When the osmolality starts hitting 320 or 330 milliosmoles per kilogram, you often see a significantly increase in neurological symptoms, such as even coma or obtundation. Now, looking at the pathogenesis of these two conditions, they have a very similar pathogenesis, and then two aspects to it. There is the insulin deficiency or the insulin resistance aspect, and of course there's also the glucagon excess, and not just glucagon, there are other counter-regulatory hormones that also go up. So counter-regulatory hormone excess, and these include hormones such as cortisol, growth hormones, and catecholamines. Now, of course, what basically precipitates these two disorders? And the precipitants usually are either a lack of compliance, so people are not taking their meds the way they're supposed to be taking them, and the other aspect is infections, often a common cause. Rarer causes include MI, so heart attack, trauma, stroke, ethanol or drug abuse, and of course pancreatitis. Now, going back to the question of why is there less hyperglycemia in DKA, there are two reasons for that. Usually the patients present earlier because of the ketoacidosis, The ketoacidosis causes symptoms such as shortness of breath and abdominal pain, so these patients usually show up earlier. And secondly, there's less hyperglycemia because these patients are usually younger and they have a higher GFR, a higher glomerular filtration rate, and so they're able to secrete more of the glucose. Now, some of you may be also wondering, why is there no ketoacidosis in HHS? And the reason for that is that the basal insulin secretion in HHS is high enough that it actually suppresses the ketoacidosis. Remember, you need less insulin to suppress lipolysis than you need to suppress the gluconeogenesis and some of the other processes. And getting to the gluconeogenesis and some of the other processes, let's look at the mechanism. So the mechanism of DKA and DKA and HHS. So there are four key aspects to this. You have an increase in the gluconeogenesis, and this is both hepatic and renal gluconeogenesis. You have an increase in the glycogenolysis. You have decreased peripheral tissue uptake. So decreased uptake by peripheral tissues of the glucose is often a contributing factor as well. And in addition to the decreased peripheral tissue uptake, you also have the increased lipolysis. And of course, what this does is that these three processes increase your glucose, which when the glucose exceeds the renal threshold, you have secretion in the urine, you have osmotic diuresis, which then causes two problematic things. It causes loss of lights, loss of electrolytes, and of course loss of fluid. Both of them are dangerous. The loss of fluid, of course, is the one that can cause decreased tissue perfusion and lactic acidosis. So can cause the really nasty effects of these conditions. The lipolysis basically causes an oxidation of the free fatty acids and generation of ketone bodies. Acetoacetic acid is the first one produced, and that can either be reduced to beta hydroxybutyric acid or acetone. Now, if you look at your ACE test or your nitroprusside test, that actually detects this and this. It does not detect this. So your nitroprusside test can be falsely negative. If you do find that your nitroprusside test is negative and you do suspect DKA or HHS, simple thing to do is basically add hydrogen peroxide, which then converts your beta hydroxybutyric acid to your acetoacetic acid, and therefore making it detectable. Now, some of the symptoms of these conditions are, and are not limited to, for DKA, you have your polyuria and polydipsia, so you increase output and increase input. You have your ketoacidosis from DKA resulting in nausea, vomiting, and abdominal pain, and also that fruity breath. And if you look at HHS, you also have your neurological symptoms. That's often when it exceeds 320 to 330 milliosmoles, where you start seeing that. And the neurological symptoms include things such as coma, obtundation, hemiparesis, hemianopsia, and even seizures. On exam, of course, you see a couple of things. You see volume contraction, so symptoms of volume contraction, which include your increased heart rate, your decreased BP, the usual stuff, your decreased JVP, decreased cap refill. You also have confusion, the neurological symptom coming in there, but that's more due to volume depletion, not so much due to the hyperosmolar state. And you have your decreased skin turgor, and dry axilla, dry oral mucosa, etc., etc. Now, if you look at the acidosis aspect, you see tachypnea, you increase respirate, and you see Kussmaul breathing, which is key. These are really deep breaths that these patients take when they are in this acidosis. Now, continuing on, labs. So you're going to continue the labs aspect of this presentation in the next video. Thank you, and stay tuned.